evening, one and all. We thank you all for gathering today for an academic feast that is to follow on atrial fibrillation and its caveats. As you all know, atrial fibrillation is one of the most common arrhythmias that is seen in clinical practice. The importance of palpating and recognizing an irregular pulse was always something that was stressed upon during our medical college days. And as you all know, complications for atrial fibrillation are multiple, including the very dreaded ischemic embolic stroke. Caveats to managing the same include strategies such as anticoagulation, rate control, and rhythm control. To throw more light on the same, we have two prolific speakers who need no introduction in medical circles. Dr. Rajat Sharma and Dr. Brian Pinto. I, Dr. Parthasarathi from Macleods Pharmaceuticals, take the pleasure of introducing both our prolific speakers for the day. Sagar, I'm not able to go next. Yeah, thank you. So we have with us first Dr. Rajat Sharma, who is a senior consultant cardiologist and electrophysiologist from Mohali. He's currently working as a cardiac electrophysiologist at Fortis Hospital, Mohali. He had done his core cardiology residency from PGI Chandigarh and had received his fellowship in cardiac electrophysiology from Queen Elizabeth Royal Infirmary, Dalhousie University, Canada, as well as his fellowship in advanced cardiac electrophysiology from the very reputed UCLA, USA. Also, he was awarded fellowship of the Heart Rhythm Society, USA, the fellowship of American College of Cardiology, and the European Society of Cardiology. His key areas of interest include sudden cardiac death, VT ablation, complex arrhythmia management and ablations, inherited heart disease and channelopathies, with a keen interest in teaching and research. Next, we have Dr. Pinto, senior consultant cardiologist from Mumbai, currently serving as the director of cardiology and cardiovascular services at Holy Family Hospital since 2002 to date, and is also attached to multiple hospitals across Mumbai. He had received the Economic Times Award 2020 as a cardiologist and has also been a DNB teacher for cardiology since 2007. He has been a pioneer of transradial interventions in India since 2002 and a proctor for transradial interventions and has conducted numerous live demonstrations at CSI as well as other national and international podiums. He's been a recipient of the William O'Neill Award for Excellence in Cardiology and has been the Secretary General of the India International Forum of Cardiology and has conducted multiple annual meetings of the same. He was also part of the Guidelines Committee in India for Transradial Interventions and Renal Protection. He has conducted 24 registries and drug trials, for example, the OSS-8 Rival, PHT-48 Signify, and has more than 25,000 interventional procedures and 15,000 transradial interventions to his credit. So as our session goes ahead, we would have our first speaker, Dr. Sharma, speak on anticoagulation, a cornerstone in atrial fibrillation management, followed by Dr. Pinto discussing on rate and rhythm control, when, why, and how. Following the same, we would have an audience Q&A on the same. Without spending any more time, I hand over the session to our esteemed first speaker, Dr. Rajat Sharma, sir. Over to you, sir.
Thank you. Yeah, thank you all the speakers and the host for conducting this wonderful and very relevant talk around atrial fibrillation. As we all know, this atrial fibrillation is one of the most common cardiac arrhythmia, and in fact, it is the most commonly seen cardiac ailment in today's practice. So whether we are practicing internal medicine or cardiology or general practice, we need to understand the two main aspects of atrial fibrillation, that is how do we prevent a stroke and how do we manage the atrial fibrillation so far as the rhythm is concerned. So Dr. Pinto will be talking the rhythm and the rate control part, and I'll be just focusing on the oral anticoagulation in atrial fibrillation. So when we talk about the oral anticoagulation in atrial fibrillation, we have numerous guidelines have come. We have numerous literatures are available so far as the do's and don'ts of atrial fibrillation from an anticoagulation perspective. And there are still some kind of gray areas where we haven't got the right kind of reply or the answer to our anticoagulation strategy in atrial fibrillation, particularly in renal dysfunction and other situations. We'll try to simplify this talk so that it will be understandable to most of the audience. We'll not talk something super technical about it. So I have divided this talk into a couple of things, like we'll discuss basically about the what is the current guideline says so far the anticoagulation is there. So if you remember, this guideline changes almost every 2 to 3 years because of the new guideline, new studies and RCTs they come, and we conduct certain kind of studies in different populations, and accordingly we plan our or refine our strategy for an anticoagulation in atrial fibrillation. So when we talk about an atrial fibrillation, we should not be talking about a valvular atrial fibrillation or a non-valvular atrial fibrillation. So as per the definition, the valvular atrial fibrillation means it is a mechanical prosthetic mitral valve or a significant mitral stenosis. And non-valvular atrial fibrillation is something other than that. So suppose you have an atrial fibrillation other than these two conditions, so probably that is a non-valvular atrial fibrillation. So the distinction of these valvular and non-valvular atrial fibrillation seems quite attractive today, but I hope this distinction won't stay after some time. That is my belief. Why I believe so? So we are not going to discuss about that. Time will tell how the things are going to happen. But as for today, when we are encountering a patient in our clinic with a non-valvular atrial fibrillation, then we have to risk stratify this patient based on the existing scoring system. So particularly that is the CHADVAC score. And if we are encountering a high risk population, then probably we have to risk stratify the bleeding risk, because these potential drugs comes with bleeding. So we need to understand these two scoring system, then we start the anticoagulation therapy. So that is not a very difficult task. So if we look at the 2016 versus the 2020 guideline, so far as the prevention of the thromboembolic event in atrial fibrillation is concerned, here we are now more concerned about the bleeding risk assessment that I was talking about. So when we are identifying a patient for an anticoagulation strategy, it is very, very important to risk stratify what are the possible bleeding risk. So from 2016, when it was a 2A indication, now it is a class 1 indication to assess the bleeding risk. Now coming to the other part, that is a Hasbled score. So far the risk assessment is concerned, this is a very simple tool by which we can identify what are the possible bleeding risk in high risk population. So when you're dealing with a very low risk population, we may or may not do the Hasbled scoring, but eventually over a period of time as the patient progress with the anticoagulation, probably that will be more meaningful. So this is a class 1 indication as per the guideline today. Now coming to the another thing, that is the people who were on vitamin K antagonist, and they had a low time to therapeutic range that is less than 70%. So in such kind of population, we straight away switch the patient to NOACs rather than trying to optimize the TTR over a period of time because of the huge amount of evidence that we have got in our RCTs and real world evidences. So it is a meaningful strategy to switch over from vitamin K antagonist to NOACs in such kind of population where we are finding it very difficult to maintain an therapeutic TTR. Now coming to the other criteria that we need to have an atrial fibrillation which is less than 24 hours. And if the patient has a low risk, then post cardioversion, we need to anticoagulate at least for 4 weeks. And if the patient is not on an oral anticoagulation before an pulmonary vein isolation or any kind of fibrillation ablation, then also we must start an anticoagulation at least 3 weeks prior to the scheduled ablation. So this is in class 1A recommendation. And when we do a catheter ablation, we need to continue the warfarin or the NOACs, whichever the patient is getting, uninterrupted. We don't have to stop the medication for any potential transseptal access or ablation procedure. Now coming to post or pericatheteral ablation, initially we were giving the anticoagulation for 8 weeks after catheter ablation. And that was a class 2A indication. Now, with the success of this ablation procedure and maintaining the patient in sinus rhythm, with an initial successful pulmonary vein isolation, we can technically stop the anticoagulation after 2 months. But this is valid for people who are a low risk patients. But if we're dealing with a high risk patient, probably we need to continue it for a longer time. So this we have discussed that patient with a low risk, we need to give it for 4 to 6 months. Now coming to the patient with cardioversion. If we are certain about the atrial fibrillation duration, which is more than 24 hours, and once the patient had a successful cardioversion, we need to continue the anticoagulation for 4 weeks. And if the patient has got a high risk or a high Chadwick score, probably we need to continue it for a longer time, maybe lifelong. Now, what is the current guideline says so far as the oral anticoagulation in atrial fibrillation is concerned? As we all know, all the novel anticoagulants, including the warfarin, are the class 1 indication. Based on the Chadwick score, if it is greater than 2 for men and greater than 3 for women, we need to anticoagulate the patients. It is not dependent on the type of atrial fibrillation, whether it is a paroxysmal, persistent, long-term persistent, or a permanent atrial fibrillation. Now coming to the NOACs, all the four NOACs are probably recommended over warfarin because of the superiority so far as the stroke prevention is concerned, except in patients with a moderate to severe mitral stenosis or patient who has a mechanical metallic heart valve. And as we discussed that if we are finding it difficult to maintain an INR with an vitamin K antagonist, we can straight away start an oral anticoagulant. In patient with atrial fibrillation, except in patients who has a moderate to severe mitral stenosis or with mechanical heart valve, we need to ensure the Chadwick score so that we can implement the anticoagulation strategy. As for today, in mechanical heart valve, vitamin K antagonist is only recommended, because there is a small study that happened and there was increased mortality and adverse reactions. So it was decided that vitamin K antagonist probably is superior in such kind of cases. And when we are selecting an anticoagulant, it should be purely based on the risk of thromboembolism, irrespective of what kind of atrial fibrillation it is. Just like the way I said, whether it is a paroxysmal, persistent, or a permanent, the thromboembolic risk is the same in all the spectrums of atrial fibrillation. It is dependent on the CHA2DS2-VASc score rather than the type of atrial fibrillation. So this has to be very, very clear. Now, when we are dealing with a patient with an atrial fibrillation, by very nature of this disease, we are going to have certain amount of renal impairment and occasionally hepatic dysfunction. So when we are instituting this novel anticoagulant, we need to assess the renal function and the liver function from time to time, at least annually. And when we're talking about an anticoagulation therapy in atrial fibrillation, it should be individualized on the basis of your discussion with the patient about the absolute risk reduction, relative risk reduction of the stroke, possible bleeding outcomes, and so many other things. So we should not just simply write an anticoagulant and just get up. When we are talking about an atrial flutter, again, it carries the same importance so far as the atrial fibrillation is concerned, and we have to anticoagulate this patient just like an atrial fibrillation. And re-evaluation of the need for and choice of anticoagulant should be done on periodic intervals, and that will decide our bleeding risk and other outcomes. Now, if a patient with atrial fibrillation is unable to maintain the therapeutic INR, then we should better switch to novel anticoagulant. And as I told, that in atrial fibrillation, we have to assess the risk score before we start an anticoagulant. Now, if we are dealing with patients with renal dysfunction, then we must assess the creatinine clearance, or the patient is on a renal replacement therapy, and accordingly, we should use novel anticoagulant. As per the current recommendation, vitamin K antagonist and an apixaban is advised in such kind of situations. Now, for patients with atrial fibrillation, non-valvular atrial fibrillation, if the patient has a moderate to severe renal dysfunction, then we should try to assess the creatinine clearance. And if the creatinine clearance is between 15 to 30 ml per minute, then possibly apixaban can be given. Dabigatran should be avoided in creatinine clearance of less than 50. And when we are dealing with a creatinine clearance of less than 50, the rivaroxaban needs to be reduced. So there is a appropriate dose reduction criteria for all the drugs that we'll be discussing later. So if the patient has got an end-stage renal disease, or if the patient is on dialysis, like the direct thrombin inhibitors like dabigatran, or factor 10A inhibitors like rivaroxaban and apixaban are not recommended. So only apixaban or vitamin K antagonist are recommended as per the guidelines. However, there are certain studies that has come up which are leaning towards the use of rivaroxaban as well. And from our bitter past experience, like dabigatran study in mechanical heart valve, it is a contraindication. Now, when we come across atrial fibrillation, we'll have n number of patients undergoing some form of percutaneous intervention. Then it becomes a complicated scenario so far as the antiplatelet and anticoagulation is concerned. If we are dealing with a patient with an acute coronary syndrome and patient has undergone an uncomplicated PCI, we possibly safely stop the aspirin within 1 week and continue with a dual therapy. That means one P2Y12 inhibitor and an oral anticoagulation. So when we talk about the P2Y12 inhibitors, that is clopidogrel possibly is the most preferred. And that needs to be continued for 12 months. And then later on, we can continue with a monotherapy with an anticoagulant. And if the patient has got a chronic coronary syndrome and patient has undergone a PCI, which is uncomplicated, again, we can stop the aspirin at 1 week and stop the dual therapy at 6 months and continue with a monotherapy. So in all the patients eligible for NOACs, it is always recommended to use a NOAC in preference to a vitamin K antagonist when we are dealing with some kind of coronary interventions. And if the patient has got a high Hesbled score, we need to reduce the dose appropriately, like rivaroxaban, 15 milligram, and we can continue with the same strategy of double antiplatelet double therapy. When we are dealing with the patients with a high Hesbled score and we have a plan to give dabigatran, we must use 110 milligram BID. And vitamin K in combination with the antiplatelet therapy, which has been done in the past also. So we need to carefully regulate the INR, and we should keep the typical INR at 2 to 2.5 with a TTR of more than 70% to have an appropriate stroke prophylaxis. Now, when the patient has gotten ACS with an uncomplicated PCI, as we discussed in the past, that we need to stop the aspirin within 1 week and continue with a dual therapy for 12 months. Triple therapy, that is aspirin, clopidogrel, and oral anticoagulation for more than 1 week after an ACS should be considered when there is a strong risk of stent thrombosis. But that is a class 2A indication. So it is the interventional cardiologist who is going to decide, depending on the position of the stent and the kind of coronary anatomy. That decision is absolutely to the interventional cardiologist who is going to take a call on this triple therapy and the duration. So this we have discussed. So this is just a cartoon to say what all we have discussed. And the take-home message is, after an ACS, we need, or a CCS, we need to stop aspirin. And if it is an ACS, then probably we continue with the dual therapy for 12 months, 9 to 12 months, and then monotherapy. And if it is a CCS, then probably we have to stop it as early as 6 months. So this kind of strategy probably has made the things slightly simpler. But when it comes to an interventional cardiologist, they find it difficult because they have done a lot for the coronary revascularization and their decision is the final. So when we are dealing with such kind of tricky populations of atrial fibrillation with a stent who requires both antiplatelet and anticoagulant, there are certain kind of thrombotic risk factors that we all know about, like a diabetes, multiple cell disease, and peripheral artery disease, premature coronary artery disease, or with patients with the renal dysfunctions. These are the patients are prone for more thrombotic risk. If the patient has an episode of acute coronary event, or patient has undergone a very complex revascularization like a Lippmann stenting or a bifurcation stenting or a CTO revascularization, or the patient has a multivessel revascularization, or the patient has a history of stent thrombosis in the past, or some antiplatelet resistance. So these are the potential thrombotic risk factors that we need to keep in our mind so that we can plan our antiplatelet and anticoagulant therapy appropriately. When we are dealing with such kind of population, we have an bleeding risk also. So if the patient has got an uncontrolled blood pressure, or patient has renal dysfunction, liver dysfunction, history of prior stroke or intracranial bleed, or patient has a history of bleeding diathesis or a liver liner in the past, or patient is quite elderly, or patient is taking some kind of drug that potentially can increase our bleeding risk, we need to take a note of this possible bleeding risk factor, which may affect our anticoagulation or antiplatelet strategy following a PCI. So what are the things that we can do to reduce this? So possibly, as Dr. Pinto is a master in radial intervention, so that is the way where we can potentially reduce the risk of bleeding or a groin hematoma. PPI in patients with double antiplatelet therapy who are at risk of bleeding, like GIT bleeding, or patient who are elderly, or patient has got some kind of helicobacter infection or certain things, or if the patient is getting GP2B3 inhibitors during the procedure. So these are the kind of things that we need to look at. Now, coming to the population of CKD. So as we know, atrial fibrillation and renal dysfunction are inseparable spectrum of the same disease. Thereby meaning, if a person has an atrial fibrillation, he is bound to have a gradual renal deterioration over a period of time. And similarly, if a patient has got a underlying CKD, his chances of developing an atrial fibrillation is significantly high. And these are the population of CKD who are in need of an anticoagulant much more than a person with a normal renal function because of an increased risk of systemic thromboembolism and particularly ischemic stroke. If you look at all the RCTs, these population of CKDs are frequently excluded, or they are not seen in a very large proportion. So getting an evidence from these RCT, so far the efficacy and safety of these anticoagulants are slightly hazy or gray. And if you look at the risk scores, like the thromboembolic or the hemorrhagic risk scores, they don't actually define the bleeding risk or the hemorrhagic stroke just like a normal population. So in such kind of populations of renal dysfunction, again, the pharmacodynamics or the pharmacokinetic of these medications, they are slightly altered. So we can anticipate a different kind of action than the normal population when we are dealing with such kind of population. So we should be very, very careful. So we need to have assess the renal dysfunction, and we have to check out our treatment plan. But unfortunately, till today, there is no consensus recommendation of oral anticoagulation in CKD, particularly stage 4 and stage 5. But we have certain guidelines so far as the dose reduction or appropriateness of the oral anticoagulants are concerned. Suppose you look at the vitamin K antagonist, it is applicable for all spectrum of the CKD. Although, when we are dealing with higher grade of CKD, we are bound to have increased risk of bleeding. But if you look at the dabigatran, we should try to avoid giving dabigatran in patients who has got a reduced GFR, maybe 30. When we're talking about rivaroxaban, This is a very important point because when we write rivaroxaban, and if the patient's creatinine is coming to around 1.4 or 1.3, we write a full dose of rivaroxaban. But if you calculate the creatinine clearance, it may be somewhere around 46, 47, or 43. So we are inappropriately giving a higher dose of rivaroxaban in this population where we are thinking that possibly this person has a normal renal function. So it is very important to calculate the creatinine clearance and write it down in each and every prescription hours so that over a period of time, we can titrate the dose of the anticoagulant appropriately. Apixaban has a very standard dose reduction criteria, unlike a rivaroxaban where it is 49 cutoff. So when we are dealing with a person who is elderly, more than 80, or weight less than 60, or the creatinine is more than 1.5, we reduce the dose to 2.5. And edoxaban, just like a rivaroxaban, we reduce the dose once the creatinine clearance is less than 49. Now, none of these guidelines actually tells us like how we need to anticoagulate our patients with chronic kidney disease. So these are the things that we discussed in the last slide. But if you look at as the creatinine clearance declines, like from above 80 to less than 50, we have a significant increase in the systemic embolization as well as the bleeding risk, which grows significantly higher than the ischemic stroke. So this is the important factor that we need to keep in our mind when we are anticoagulating the patients. So to simplify our strategy, if the GFR is between 30 to 60 ml per minute, we can safely give all the anticoagulants. But if you look at the apixaban data, it is possibly slightly safer. If the GFR is lesser than 50 to 30, then probably we can still give apixaban, and vitamin K antagonist is actually applicable for all spectrums of GFR. So accordingly, we should plan our anticoagulation strategy. Now coming to the contentious issue of valvular heart disease versus a non-valvular heart disease, how they are different so far as the anticoagulation strategy is concerned. So there have been studies, the RCT meta-analysis, they have shown the 6 RCTs, they were included over 13,000 patients, and they had a assessment that the NOACs actually significantly reduce the risk of stroke, systemic embolization, intracranial hemorrhages, and major bleeding. But unfortunately, we cannot take this as an article to start anticoagulation in patients with a significant mitral stenosis because we do not have a clarity regarding how many patients of these RCTs actually had a significant mitral stenosis or a mechanical heart valve. So time will tell, and future studies will tell, like how we are going to start anticoagulation in such kind of population. So suppose it is a stroke, major bleeding, or intracranial bleeding. So it was quite favorable so far as the NOACs are concerned. So to conclude, NOACs are actually advantageous over vitamin K antagonists and appears to be significantly reducing the risk of stroke and systemic embolization, including the intracranial hemorrhage in patients with a valvular heart disease. So when we talk about a valvular heart disease, that means possibly significant of the patients did not have significant mitral stenosis or a metallic valve. Now, how do we choose this NOACs? So that is the most important topic. So we all know who are the patients who should be getting a NOACs. So when we are choosing an anticoagulant, we must look at the creatinine clearance, any history of GI bleeding, or what are the concomitant medications that we are giving. If the patient falls into a low bleeding risk, then we have to select the NOACs because it has a meaningful effect so far as the ischemic stroke reduction is concerned without increasing the other bleeding risk. But if the patient has a high bleeding risk, then we have to find out a NOAC which has got a most favorable bleeding profile. And if we do not have any option, possibly a vitamin K antagonist. So far as the once daily or twice daily dose, it is a personal choice. However, none of the trial has shown any kind of superiority or inferiority of a once a dose versus twice a dose. There are certain kind of hypothetical explanation for and against both this strategy. However, in a clinical scenario, everything is fine. Now, finally, so far as the availability of the concern, so far as the region is concerned, then we have to take a decision based on that. Now, coming to very less clear situations related to atrial fibrillations like cryptogenic stroke or high atrial activity or a post-operative atrial fibrillation. So we all know, like in patients who has an intracranial bleed, how do we start the reinitiate the anticoagulation? Because that is all dependent on the magnitude of the intracranial bleed that is assessed by the neurologist, and based on that, we reinitiate the anticoagulation at 0, 3, 6, 9, 12 days. And so far as the long-term secondary prevention is concerned, that is all dependent on the Chadwick score or the risk of thromboembolism following an ischemic stroke. And if the patient has got a stroke, giving initial 2 days of unfractionated heparin, low molecular heparin, or vitamin K antagonist is actually not recommended. So we should not try to give this thing in patients who has got an ischemic stroke in the initial state. And we must reinitiate in high-risk ischemic stroke the oral anticoagulation as per the guidelines. So depending on the severity of the stroke, we reinitiate. And so far as the bleeding is concerned, in patient who has got an anticoagulation, we have got different strategy to treat, that is withholding the medication and certain general profile for the bleeding management and certain kind of antidote if it is available and other blood components. So these are the strategy. So far as the post-operative atrial fibrillation is concerned, they should be equal to the anterior fibrillation until unless proved otherwise. So based on the Chadwick score, we need to risk stratify this population and give the anticoagulation. So that is a class 2A indication, and that is how the things are. Now coming to the high rate atrial activity. So studies have proven that the stroke risk is significantly higher in such kind of populations. Suppose we have a device detected atrial fibrillation or a high rate atrial activity, they should be analyzed at par with the atrial fibrillation, and we have to plan our anticoagulation strategy. So we have to institute the same risk scoring system, and we have to anticoagulate these patients. Now coming to the elderly populations, so we have seen from our anticoagulation trials that most of the anticoagulant, whether it is a dabigatran, rivaroxaban, epicoxaban, or edoxaban, they have a significantly better risk profile so far as the ischemic stroke is concerned particularly. However, the bleeding risk is slightly unfavorable in a higher doses of these medications. So according to the age and the frailty of the patient, we must try to institute the right kind of therapy. So this is the coming to the last part of it, that the risk stratification. So we use the Chadwick score commonly. However, there are certain kind of pitfalls for this Chadwick score. So when we are talking about a risk score for atrial fibrillation, we have the clinical markers, electrical markers. Clinical markers are the demographic and the other associated conditions like hypertension, diabetes. And so far as the electrical markers are concerned, the burden of the atrial fibrillation, cardioversion to sinus rhythm, and the type of atrial fibrillation. And there are certain kind of biomarkers are coming in, and some imaging modality that has been now proposed so that we can have a very robust risk stratification tool. So accordingly, we should plan our therapy. So this is for today, and we'll appreciate all the question and answer after Dr. Pinto's talk.
Thank you so much, Dr. Sharma, for the wonderful talk. We now hand over the session to Dr. Pinto for his talk on rate control versus rhythm control strategies.
Just let me share my screen. Okay, has my screen come on? Hi.
No, sir, it's not visible.
It's visible now?
Uh,
Not yet?
Not yet, sir. It's not yet.
Now?
The screen is visible. Yes.
It's
The
visible.
slides also. Yes.
Thank you, Dr. Sharma. It's a pleasure to be here. That was a wonderful talk on oral anticoagulation, and all of us know it's so important in the scenario of atrial fibrillation, and with the NOACs having come to us a little more than 10 years back, I think we certainly are in a better position. But I think beyond the stroke, we also have other things to look at. As we would go forward, you can see that for a patient with atrial fibrillation who's first diagnosed is the one that we look at, a person who has been first time diagnosed with atrial fibrillation. That's a definition. And this could be a person like a holiday heart syndrome, for example, that has binge drunk and come into you for the first time, who may not need anything more than that initial beta blocker or just observation. On the other hand, you may have a paroxysmal, or this first time diagnosed patient may also go further and become a paroxysmal atrial fibrillation that terminates spontaneously, and that this intervention happened within 7 days of the onset. So if it surpasses that 1 week, then we would call it persistent atrial fibrillation going on beyond 7 days, including episodes that are terminated by cardioversion. So, even if they've been terminated, but then they occur beyond 7 days. And then we have the definition of long-standing persistent atrial fibrillation, where we're going to talk about a duration of more than 12 months, and where we have still decided to adopt a rhythm control strategy. Once we go beyond 1 year, and both the patient and the physician have said now that there's going to be only the rate control and the rhythm control is not to be undertaken, we would then define this patient as if having permanent atrial fibrillation. However, if we were to then say after some time that we are once again going to try to get the rhythm strategy in place with antiarrhythmic drugs or with ablation therapy, then we once again call this patient and reclassify this patient as a long-standing persistent atrial fibrillation. Now, looking at this slide, you would see that there are going to be more and more patients of atrial fibrillation because of the fact that we have an aging population. It's also important to realize that this happens more frequently in genetic background, parents having had atrial fibrillation, people who are the male sex would also. And on the outside, you can see that various kinds of diseases, vascular, coronary artery disease, diabetic, chronic kidney disease, COPD, obstructive sleep apnea, obesity, smoking, increased alcohol content, would also predispose to atrial fibrillation. And this is an arrhythmia which we have spoken about. But what you can see that these risk factors not only lead to atrial fibrillation, but also lead to heart failure. And all of us know that patients develop both HFrEF, HFpEF, and sometimes what they call mistakenly as HFmrEF. But here you can see that the heart is now getting into a problem. Structural remodeling is occurring both at the ventricular level, at the atrial level, and you're losing the loss of the atrial systole. You must remember that in different patients, the atrial systole is important. For example, you have a patient of hypertrophic cardiomyopathy, where the atrial kick is so important, or you have a patient who's got HFpEF, where the atrial kick is so important, or HFrEF. So you must look at the fact, and I think we are all of us, as Dr. Sharma will also agree, that we are pushing more for rhythm control now, unless it is not possible. And the initial period, about 20 years back, when we had the AFFIRM study, was that, oh, we may do rate control as our first approach in some, and still we will continue with that for some group of patients. And the reason for all this, the heart failure, as well as the atrial fibrillation, pushes our patients towards stroke, cognitive impairment, depression, hospitalization, and mortality. And here you can see that a patient could present to you in atrial fibrillation in different states. For example, you can have a silent guy who comes with, and you just detected him on the ECG, or you have these new devices, hand-holding devices. I think everybody above the age of 65 should have an ECG, should have put onto a hand-holding device, so that you can pick up more and more patients. All stroke patients should undertake that. TIA patients should undertake that. Patients at high risk should undertake that. And you can see that the outcomes in an asymptomatic patient can be as severe as death sometimes, as severe as stroke sometimes. And on the other hand, you could have symptomatic patients who come to you with different kinds of situations, but at the same time, the problem is different out over there. You will see exercise-induced problems. You would see the stable patient hemodynamically, but they're coming to you with syncope, dizziness, disordered sleep, so on and so forth. Hemodynamically unstable patients could also be there because of atrial fibrillation. Those who come to an acute heart failure, ongoing myocardial ischemia, and even in cardiogenic shock. And you can see all of this can lead to a situation where you may be in trouble, where the patients are having different kinds of problems. You would see that there would be depression in some of these patients, impaired quality of life in most of these patients, and you can see increased stroke, increased vascular events, excessive ventricular rate causing heart failure, so on and so forth. And this is the situation where Dr. Sharma already spoke about, the CHA2DS2-VASc score. I think it's important for all of us to know that a CHA2DS2-VASc score of more than 2, especially in females, and more than 1 in males, may tell us today to get onto an anticoagulant. But also to remember that the symptomatic patient is beyond that. The symptomatic patient is one who would also have severe or disabling symptoms. There could also be the severity of the atrial fibrillation burden. So you're going to look at everything. You're going to look at stroke risk, symptom severity, severity of the burden, and substrate severity. For example, patients who have the greatest subset of comorbidities, obese patients, patients who are in HFpEF, patients who have atrial enlargement, dysfunctional atrium, fibrotic atrium. We know that by the studies that we are doing today, that we can study the atrium also much better. So we would look at all of this, not only the CHA2DS2-VASc score, but the symptoms, as well as the temporal pattern of the AF, whether the AF burden is more or not, and we would clinically assess, and we would go further down the line by doing TE or doing transesophageal echo or doing cardiac MR in some of these patients. And here is the ABC pathway, which we were talking about. We talk about anticoagulation for those who have a higher CHA2DS2-VASc score, and you would choose mostly between NOAC if possible, or VK in some situations where we spoke about severe mitral stenosis. And we also would assess the symptoms of the patient, quality of life, preferences that the patient has. Of course, optimize rate control, but also consider much more severely than before a rhythm control in those patients who would benefit. And we are becoming more aware of the fact that the rhythm control is so important. And in our hospital, we tend to cardiovert so many patients in a week, maybe 4, 5, 6, because we realize that rhythm control is so important. And we also look at the cardiovascular and the comorbidities. So there we could bring in lifestyle changes, reduction for obesity, regular exercise, relaxation, reduction of alcohol, smoking, so on and so forth. So what do we look at when we are looking at the rate control therapy? We're looking just not at the rate. We're looking at the background therapy for all AF patients and what are going to be the thought processes today. In fact, after the RACE trial came out, we realized that trying to go for a heart rate of 80 and below may actually affect many patients with bradycardiac symptoms. And therefore, it has been a more relaxed approach after the RACE trial, where we look at more lenient rate control, heart rates between 110, between 90 and 110 is what we look at the sweet spot. Therapy after failure of rhythm control is another situation where we go for rate control. We may have aggressively tried for rhythm control, but then if it doesn't happen, especially in a more elderly patient, we may settle for rate control. And this all came about because the AFFIRM trial, which looked at about 4,000 patients, said to us that rate control was as good as rhythm control. I beg to differ because we have other trials after that. And therapy also occurs for rate control when the risks of returning to sinus rhythm are much more outweighing. For example, if you have to take an old patient for an ablation therapy, sometimes the risks for that patient may be too high, and therefore you may consider that you put this patient on rate control. So here you want to see that your patient is getting a heart rate which is in the zone that is above 80, between 90 and 110. You would also look for lower heart rate in CRT patients to see that biventricular pacing is going on. You would assess heart rate during exercise. You don't want the heart rate to be going too fast, too high. Keep it below 110 with the 25% duration of maximal exercise time, and then perform 24-hour Holter monitoring in all patients with atrial fibrillation. You should do a Holter for these patients because you would see many, many events where you would see whether your control is good or not. And you may also pick up other arrhythmias that may help you to really take care of these patients. You would consider, rhythm therapy or atrioventricular node ablation if symptoms, in spite of this, continue to be there, or if the LV deteriorates further, you get a tachycardiomyopathy, and then you may even consider, ablation of the node with pacing. So it's important for all of us to realize that besides the symptoms, we also look at the LV. And if the LV is showing a deterioration because of the fast ventricular rate, and we have no ability to control this with certain drug therapy, then we must go further. We must think of ablation, and we must also think of ablating the AV node at times in those group of patients who may proceed towards tachycardiomyopathy, where you can then do a biventricular pacing. And here is a very good slide which shows you how the lower heart rate versus the higher heart rate may actually be inappropriate for some patients. And the sweet spot is somewhere between 85 and 110 when we would try to achieve the best. And this is a more lenient kind of approach than trying to get it below 80. Because if you do that, you're likely to get into the adverse effects of lower situations. You may have more pacemaker implantations, and clearly this may lead to higher costs. On the other hand, if you keep your patients in the heart rate of 130, 140 and above, you will certainly have more symptoms of atrial fibrillation. Quality of life would go down quite significantly. You would get tachycardiomyopathy more commonly, increased risk of stroke, and once again, leading to higher costs. So the goals are to reduce the stroke and reduce the worsening heart failure. Now, the pharmacological therapy that would be there, which would act on the AV node in it, you can see that the atrial rate is fast. It's 100 to 600. And then the AV node acts like a junction out over there to prevent us to get into a heart rate. But when you have atrial fibrillation, you could have ventricular rates that could go very high, 170, 180. I'm not talking about situations where you also have a conduction pathway like accessory pathway. However, if you have the real AV node in place and no accessory pathway, by and large, your heart rate's about 170 at the maximum. And there you have pharmacological rate control, which you can do with beta blockers, non-dihydropyridine, calcium channel blockers, digoxin, and amiodarone. And the choice of the rate control drugs, I don't usually use amiodarone for rate control because I feel there are too many side effects for this drug in rate control. I would rather use it for rhythm control. I would use beta blockers, calcium channel blockers, digoxin as my situation. And then, of course, in patients who do not get controlled and who still are going into a tachycardiomyopathy, then you would consider catheter ablation and AV node of the AV node. The choice of drugs, as you can see, will depend upon what your patients have as comorbidities. For example, if your patient is hypertensive and has HFpEF, then your first line of treatment would be beta blockers or the non-dihydropyridine calcium channel blockers. On the other hand, if you have HFrEF, then you're going to talk about beta blockers, and you would also talk about digoxin in some situations of that. On the other hand, if you had patients who had severe COPD asthma, then non-dihydropyridine, and you have pre-excited AF, for example, you have AV node, which is being bypassed by the accessory pathway, ablation would be your choice. You still have a suboptimal result when you clinically assess these patients. Then you would go and you would add the second line of drugs. For example, you would add digoxin in some situations. You would add beta blockers or non. So you would combine these drugs. And at the last, in fact, I would implore people not to use amiodarone up front for rate control. It is to be brought in much later. The side effects of amiodarone are much too high to consider it for plain rate control. For rhythm control, that's a different ballgame completely. So consider the second line of drugs out over here, as you can see, and still you have a suboptimal result. you've added up all these drugs, then you consider the third line of treatment, which would be a combination of 3 drugs, and then the evaluation for CRT-P, CRT-D, or pacemaker implantation and atrioventricular node ablation. So this is how you would go ahead. You can see that in patients whom you're going to use rhythm control, it's a different group of drugs. For example, we very often use ibutylite in patients who come up with a QTF in our situation. However, you have to see that these patients have been either properly beta blocked or given adequate magnesium, at least 4 grams about half an hour before the procedure of giving them ibutylite, and you have to be prepared for a QT kind of situation where you could have torsade. But it's a drug that can be used. Flecainide for patients who do not have any structural heart disease, propafenone in some situations, and amiodarone are all the drugs that we have used in patients who have these who we want to get rhythm control. And here's what we try to state, that if one of the drugs fails, which is clinically acceptable, to go to another drug. There are drugs that can induce proarrhythmia, so you have to know about that. And the safety rather than the efficacy should be the primary goal. So many times I would try to use a drug like sotalol instead of amiodarone. And we can see out over here that the indications are quite different in different patients. Look at if the patient's symptomatic or asymptomatic, look at whether the symptoms are severe enough to just justify the antiarrhythmic drug therapy, look at basal ECG, look at risk factors for proarrhythmia with the drugs, how to minimize proarrhythmic risk, as I mentioned to you with the ibutylite, how to verify efficacy, adjuvant interventional and hybrid therapy may have to be considered. Now, what is this debate that has been going on for more than 20 years? This is because of the AFFIRM trial, which came out way back in 2003, I think. And this said something about rate versus rhythm control. We had 4,000 patients, but importantly, you must look that the mean patient age was 70, and you looked at all-cause mortality. Now, there was no difference in all-cause mortality. So does that mean that we can use the rate control for everybody and forget about rhythm control? So this has clearly been reduced to some extent because we had other trials that came out, which I will take you through as we go further. Here you can see that there's no significant, the race 2 trial shows you that the lenient rate control would be non-inferior to strict rate control in patients with permanent AF, and the patients enrolled were about 614. Heart rate control achieved the use of beta blockers, non-dihydropyridine, calcium channel blockers, and you can once again see that here also there was a non-inferior situation where patients had a more lenient rate control compared to those who had a more strict rate control. So the limitations of course, of the AFFIRM and the RACE trial is that these were the early trials. They studied pharmacological rhythm control without the addition of ablation in the therapy arms. So today we have so many more ablations going on all over the world for atrial fibrillation. And second, these trials compared 2 different management strategies and not AF versus sinus rhythm. So specifically in the AFFIRM, AF persisted in many patients in the rhythm control arm, many a times, and sinus rhythm was maintained by many patients in the rate control arm. So really we could not look at it very well. It is possible that a beneficial effect of rhythm control may have been lessened by the inconsistent use of anticoagulation. So you know now today that we would certainly use anticoagulation even if rhythm control is achieved, except in certain very special situations, as have been shown by Dr. Sharma. In AFFIRM, the majority of strokes occurred in patients who discontinued the anticoagulation based on that principle, the perception that the rhythm control strategy had been successful, which is not true. You now know that in spite of that, we know that patients may go into episodes of atrial fibrillation and also may develop strokes in spite of being in sinus rhythm. Many a times we know that atrial fibrillation patients, the time of the stroke is when they move from atrial fibrillation to sinus rhythm. AFFIRM and RACE trials did not include catheter ablation in the rhythm control arm and included patients with AF for much longer duration. The mean ages were pretty old, 70 and 68, and approximately 1/2 of the AFFIRM who had detailed history had symptomatic episodes of AF. And this was a situation where we had to look to. The use of antiarrhythmic drugs in AFFIRM was associated with a significant increase in mortality, which was due to non-cardiovascular causes, while the presence of sinus rhythm was associated in the AFFIRM trial with a significant reduction in mortality. So those who achieved sinus rhythm, when you looked at that subset, they had an improvement in mortality. A similar benefit was seen in sinus rhythm, and therefore all of us in the DIAMOND trial had compared dofetilide to placebo with reduced left ventricular ejection fraction. So in those patients who achieved sinus rhythm, they significantly did better than those who did not. One interpretation of these data is that maintaining sinus rhythm may be beneficial if there was a safer, more effective approach than the current antiarrhythmic drugs. So clearly antiarrhythmic drugs also have their side effects, also have the situation of causing non-cardiovascular mortality, and therefore we must look at them very, very stringently before we advise them. Both trials showed for cessation of anticoagulation trial 4 weeks after the documentation, which I don't think was the correct thing to do, leading to a much higher rate of stroke. It has been postulated that the continued anticoagulation might have led to a low mortality in the rhythm group. And then we came to the East AFNet trial, which has to some extent helped us to look at what we really want to look at. The rhythm control versus the usual care of rate control among patients with a recent diagnosis of atrial fibrillation. And these were about 3,000 patients. The duration of follow-up was 5 years. The mean patient age again was 70. Early rhythm control required antiarrhythmic drugs or atrial fibrillation, as well as cardioversion of persistent AF, to be initiated early after randomization. So you went to these patients pretty early after their diagnosis and gave them the chance of getting into rhythm control. Usual care was initiated, treated with rate control therapy without any possibility of, unless they went spontaneously into rhythm control. The trial was stopped due to early and better efficacy of the rhythm control arm. The primary outcome of CV death, stroke, hospitalization for heart failure, or acute coronary syndrome for rhythm control versus usual care was 3.9 versus 5 for 100 person years, showing a hazard ratio of 0.79 and these confidence limits giving us a p-value of 0.005. So this showed us that it was certainly better to go for the rhythm control. It was a smaller group of patients, but who received better forms of therapy. Therapy was the objective, whether the early rhythm control was associated with lower risk of CV outcomes, and that was shown. Rhythm control strategies not only used antiarrhythmic drugs, but also used ablation and also cardioversion, which we do in our practice. And both groups were in the first year of AFib diagnosis with at least 2 CV conditions. And you can see that there was a definite reduction in the CV death and in the stroke rate and so on and so forth. Early rhythm control was associated with the lower risk of CV outcomes than the usual care among patients with early atrial. So when the patient comes early, you must aim for the rate control. Of course, you would look at other factors like the size of the LA and so on and so forth, because some patients may come to you ostensibly early, and actually they've been in atrial fibrillation for a period of time which is much longer. So what are the ASC recommendations of 2020? The 3 drugs, beta blockers, diltiazem, and verapamil are certainly recommended as class 1 level B for LVEFs of greater than 40%. However, beta blockers and digoxin, which also work on heart failure, are recommended to control heart rate when the LVEF is less than 40%. Combination therapy comprising different rate control drugs should be considered definitely if single drug dosage do not achieve the target heart rate. Be more lenient with your patients. Try to get a heart rate of 110. So the lenient rate control should be considered, and the initial heart rate target not aim for 80, because this has a 2AB indication because of the increased number of side effects that this could cause. Atrioventricular node ablation should certainly be considered to control heart rate in unresponsive patients or those who are intolerant to intensive rate and rhythm control therapy and not eligible for rhythm control by LA ablation, accepting that these patients will certainly become pacemaker dependent, 2AB. And in patients with hemodynamic instability, clearly you need to go much more aggressively, or depressed LV function. Intravenous amiodarone may be considered right up in front for the control of acute heart rate. So the choice of therapy would depend upon, in the broad population, decisions regarding rhythm and rate control should be done after a detailed discussion and an approach with the patient of the benefits and the risks of each approach. While it may be intuitive that an individual patient would feel better by sinus rhythm, not all patients would feel better. In many cases, the benefits and risks have to be closely balanced in elderly patients, especially, and either strategy may be a reasonable choice. So you don't have to jump onto the rhythm strategy for every patient. However, younger patients who have got structural heart disease would certainly benefit from the rhythm control. For many asymptomatic patients, we prefer at times, especially elderly patients, the rate control as the initial approach, particularly if the AF is long-standing, more than a few years. For many symptomatic patients, on the other hand, particularly those who are at a high risk for a cardiovascular event and an AF diagnosed within a year, so shorter duration, symptomatic, more chances of developing an event, then we would prefer the rhythm approach. This is based on all these trials, the results of the AFFIRM and RACE, so certainly better outcomes with rate control in long-standing AF, while the risk of thromboembolic complications remain comparable. However, when you look at proarrhythmia side effects of the antiarrhythmic drugs, which are less tolerated in the elderly, making it a less resounding choice for therapy. So you have to balance that antiarrhythmic therapy, especially in the elderly patients. However, you cannot forget the East Apnea 4 trial that took on patients who came early with atrial fibrillation, so-called early. Within 1 year, expands the evidence that is the recommendations can be made for the can also be made for the very elderly, as over 25 of patients who are older than 75 years. So you cannot just write off the elderly patient and say that you would only do rate control for him. You clearly have from this trial that many of them could benefit from the rhythm control. And the preferences for rhythm control would be patients who have come within 12 months of the initial diagnosis with a high CV risk status, failure of the rate control strategy, patients having rates above 160, 150, in spite of you trying for that, and then persistence of symptoms despite adequate rate control. So you have a patient who's coming in symptomatic all the time. In such patients, RF ablation or RF ablation of the AV node would serve as an alternative to AAD therapy. So I'm going to get away from these two slides. What I would say is the learning points. The disease burden of atrial fibrillation and its consequences are very well established. Treatment strategies are aimed at minimizing symptoms. Although the early trials did favor rate control, but now we know from the East Apnea that the rhythm control is now getting to be a better approach in a bigger number of patients, especially those who are younger, those with structural heart disease, those in whom the atrial kick matters. Hence, the current recommendations are leaning more towards rhythm control, especially in patients who have come early. Look at the LA size also. Rhythm control therapy is recommended to improve both symptoms as well as quality of life. While weighing in the benefits of the reversion against risks, patients with AF should be offered a chance of restoring sinus rhythm. We must talk to them about it, irrespective of the disease duration. And I have a number of patients like that, especially in the subset with a high CV risk. In this background of the addition of ablation therapy, the success of rhythm control can greatly affect the overall disease burden in the community. So when you have that available to you, that may clearly be beneficial. And all patients with one failed attempt, intolerant to class 1 and class 3, should be offered catheter ablation. So you have a patient on board, you're trying to get him onto a drug antiarrhythmic, he's intolerant to it, or he's having a lot of symptoms, then he can be offered catheter ablation therapy, pulmonary vein isolation. And lifestyle interventions are also extremely important. You have weight loss, augmented treatment strategies, and a definitive role for the management of AF. Thank you very much for your attention.
Thank you very much, Dr. Pinto, for the fantastic session on rate control and rhythm control strategies in atrial fibrillation. We request you to on your camera, dear sir. We have a few questions from the audience. We have a few questions from the audience. The first question goes to Dr. Sharma. Dr. Sharma, a question which has come from the audience. In those atrial fibrillation patients who have suffered an acute ischemic stroke, there are two challenges. First, the risk of hemorrhagic conversion of stroke and the increased blood pressure due to the cerebral autoregulation. Sir, in your opinion, after an acute ischemic stroke, when would be the right time to initiate anticoagulation in an atrial fibrillation patient?
Yeah, that is a very relevant clinical question. Like many of the time when we have an ischemic stroke or a hemorrhagic stroke, whether the patient was on anticoagulation or without an anticoagulation. So the timing of reinitiation or initiation of an anticoagulation therapy is dependent on the magnitude of the stroke. Suppose there is a TIA, the anticoagulation can be started on the same day. And depending on the scoring that the neurologist make, so far as the magnitude of the interstitial bleed or ischemic stroke, so they categorized into different category. And suppose it is a TIA, you can start it on the 0 day. If it is a mild stroke, then probably 3 days, 6 days, 12 days, and so on. So it all depends on what is the magnitude of that infarct or the stroke. So far as the hemorrhagic transformation is concerned, so hemorrhagic transformation is usually associated with a larger stroke, but doesn't necessarily mean that smaller stroke won't have a hemorrhagic transformation. And when the hemorrhagic transformation is there, so the neurologist actually assess the progression of this hemorrhagic transformation by doing a serial CT scan. And once they are certainly sure that the hemorrhagic transmission is not worsening and they have to reinitiate the anticoagulation, they can reinitiate the anticoagulation, but with a close watch that there is no further increase in the hemorrhagic transformation.
Thank you, sir. Thank you for the clinical insight. The next question goes to Dr. Pinto. Dr. Pinto, when does a patient in atrial fibrillation need a cardioversion? What are the subsets of atrial fibrillation patients who need to get cardioversion?
I think that's an excellent question. And I would say that one, when a patient is hemodynamically unstable, okay, and has come to you in atrial fibrillation, then don't waste your time trying to do drug therapy and get him there. So hemodynamically unstable patients form the first group of patients who would need cardioversion. Secondly, sometimes post-surgical, you have a patient who has gone into atrial fibrillation, and that patient may also need cardioversion because he's becoming hemodynamically unstable. Number three are the patients in whom you see that in spite of your antiarrhythmic therapy, the patient is not responding completely and he is getting into trouble a bit. Those are the patients whom I would cardiovert. But before I cardiovert any patient, I look at a TE to look that there is no atrial clot. Also, we in patients whose atrial fibrillation has been present for more than 7 days, we would certainly put them on anticoagulation therapy, VK or NOACs, and today more often NOACs, before we cardiovert these patients. And lastly, even if a patient remains in atrial fibrillation with all the rate control and he's not responding to rhythm control drugs, or for that matter, he is in rate control but his LA size is not above 40 or 45, then I always give them an attempt to convert to it. And I've done that in many patients because at least 70% of them will get restored to the rhythm control. Another 15-20% of them may go back into atrial fibrillation, but at least 50% of them you have got back into sinus rhythm, and that's a great thing. But in those strategies, you must also have the patient on the rhythm control drugs, the antiarrhythmic drugs, for example. When you're aiming that, it's a better thing if your patient can tolerate it to either be on Cordaron, to be on Sotalol, or some drug like that, which will maintain the patient. And the last group of patients would be some patients who have no structural heart disease, but have gone into atrial fibrillation for some event, and they're not responding to any of the therapies, then I may cardiovert them as well. So there are many areas where we would cardiovert patients, but hemodynamically unstable patients is the largest and the most important of them.
Thank you, Dr. Pinto, for that insight. The next question to Dr. Sharma. So you threw light on CKD patients with atrial fibrillation, how atrial fibrillation influences CKD and how CKD in turn influences atrial fibrillation. As a clinician, as a clinical cardiologist, what are the challenges faced by you with an atrial fibrillation patient in stage 4 or stage 5 CKD?
So, as per the natural history of atrial fibrillation is there. So when the renal function deteriorates, like once the patient reaches the stage 4 and stage 5, the atrial fibrillation worsens. And in that stage, our utilization of the NOACs has not been greatly recommended as per the guidelines, except possibly the rivaroxaban, apixaban in a low dose. When the patient deteriorates the renal function, the chances of having an ischemic stroke is very high. It is 5 times higher than patient who has normal renal function. And the other part of the story is, this patient, when you anticoagulate because of the hemorrhagical problem or the hematological problem, so far as the clotting disorders, you tend to bleed. So this is a situation where there is an increased amount of stroke and there is a more increased amount of bleeding as the GFR declines. So we have to select a compound which is safer so far as the prevention of ischemic stroke is concerned, and which doesn't give an extra amount of bleeding, because these patients are more prone to bleeding also. So that is a very gray zone, and we are trying to sort it out. We have seen an effective use of apixaban in a low dose and maybe a rivaroxaban at 15 milligram dose, but that has not been featuring in the guideline, and over a period of time, probably something will come up. That is definitely going to be a difficult scenario so far as the anticoagulation is concerned, but many people prefer in vitamin K antagonists. But it do have its own demerits.
Thank you, sir. Thank you for the same. The last question of the day to Dr. Pinto. Sir, in an asymptomatic atrial fibrillation who is detected at the OPD level of a referring doctor, what, other than the ECG, what are the basic investigations that you would want done before the patient is referred to? Asymptomatic atrial fibrillation, other than an ECG, what investigations would you want to be done?
I think very importantly, you would want a 2D echo to be done in every patient of atrial fibrillation. You would also want certain blood investigations to be done. For example, as mentioned by Dr. Sharma, we need to know the renal status of the patient. So you would want a serum creatinine for every, and the eGFR to be calculated for every patient. We would certainly want that. We would want any of the comorbid kind of conditions that are there to be assessed. So tests related to the comorbid condition, and that can only come after you see the patient. So for a particular patient, you may advise this test, or for another patient, you may advise another test. But that would depend upon the comorbid conditions that this patient happened. For example, he's asymptomatic, but you can say that he may be in heart failure. Being asymptomatic also is reduced. So you may want an NT-proBNP for a certain patient. You may not want it for another patient. So clearly, the asymptomatic matter doesn't mean that he doesn't have structural disease. So it will depend upon the structural disease. ECHO gives you a good estimate of structural disease. Some blood tests like renal blood tests, hemoglobin, which you would need to know. And maybe in these times of COVID-19, You may even want an RT-PCR because you have seen so many arrhythmic events occurring in patients with COVID-19. So you may not, it's not out, it's, I would say, I would not want this thing. You called him asymptomatic, I agree. But let us say he had been vaccinated some days back, 15 days back. I would want that history. That is a history that I ask almost all cardiac patients today. I ask history of vaccination and how long back. And I ask history of COVID and how long back. So we add these two other important facts now into our management strategies, you know. And then we would want, echo would be, I think, the most important other test.
Thank you very much, Dr. Pinto, for the same. And as very well summarized by you, a 2D echo, a creatinine, of course, with an EGFR estimation, and ultimately no substitute for a good history taking along with a clinical investigation which is targeted to the particular comorbidity. Right, sir, thank you. We have no more questions from the audience, and with your permission, with the permission of both our esteemed speakers, I would like to give the vote of thanks. That's so. Very thank you, Dr. Sharma, and very huge thanks to Dr. Pinto for the amazing session that they have rendered and given to the audience. We are very sure that the audience who has attended this session has gained from the session, gained from clinical insights, and it would ultimately translate to better patient care. We also thank you, dear audience, for taking your precious time to come here, learn from the experts, enhance your knowledge, and ultimately translate into better patient care outcomes for your respective clinical practice. Last but not the least, we also thank our technology partners for the very smooth streaming of this webinar. Good evening to one and all. Thank you. Have a great day.
Thank you. Good night.
Thank you.